All right. Good afternoon, everybody.
Good afternoon.
Good afternoon. Thank you. Okay. So hopefully we're not all super sleepy after lunch. So hopefully we can keep you awake during the next 75 minutes. But I'm so happy to be here with you all. So my name is Bonnie McKinney, and I work at Youth Villages, specifically with our Intercept program. And just to kind of give you a little bit of background for me is I live in Chattanooga, Tennessee, and I've been with Youth Villages for about 18 years now. I've done many different things with the company, but mostly my time has been with our Intercept program, which we're going to talk about today. Allison is passing out some of our coverage area and contact information for our Intercept program, also a sign-in sheet. And you want to give I should tell you probably what I do at Youth Villages. So I work in our clinical services department. I am feeling like I'm tethered here. So I do like to move around a lot when I train, but because we're recording for Zoom, I'm going to be right here. So sorry about that. But I work in our clinical services department. I'm an assistant director for our clinical program for Intercept. So essentially what that means is I oversee the implementation of our program clinically to make sure we're doing it the way we're supposed to be doing it. So, and this is Allison. She's going to be my co-trainer today.
Yes. Hi, I'm Allison Anderson, and I am a licensed program expert with Youth Villages, and I am over our Knoxville Intercept teams. So I give the clinical feedback, lead the clinical consultations, review the pre-placement assessments that come to us for referrals, sign off on those. So that's what I do within that role. And then I've been at Youth Villages for 14 years.
Okay. So we want to know who you are. We want to know kind of who's in the room, so to speak. So I don't know why this is not working now. Working? Yeah, it's not advancing. Oh, here we go.
But why would technology want to work? We're all trying to be productive members of society.
No. There we go. I don't know if it's going to work. Okay. So we have a couple of QR codes throughout this training. So as you go on here, hopefully you will be able to have a question that says, what's your current professional role? So if everybody could open that up, do you have that? Is that the question that pops up for you? Yes. Yes. Okay, good. It worked. Okay. So we just want to know who's in the room. What type of program do you work for? What type of agency you work for? The reason we want to know that is so that when we give examples of how Intercept works and who we work with, we can try to make it relevant for what you all are doing. So what I want to do is be able to show us where we're at with this. So
you just minimize it and then you should be able
to. Yeah. Okay. So if you can, go ahead and choose one of those, and then you should have to hit submit. If you didn't hit submit, maybe do that because I'm not seeing anything on my end. Let me refresh.
That says please wait for the present slide. Yeah.
It says what?
Please wait.
Oh, nice. Okay, perfect. Hold on. There we go. Let's see if this will work. So not this one. Hold on. We're not going to do this one. Let's just see if this works. Okay. What did it do now? Did it give you the option?
We answered it on it.
Yeah, I've answered the question.
Bummer. Well, I tried to be all techie with this, but it's not working. Okay, so just give me a show of hands then. Who is here in like a therapist or counselor role? Anybody? Okay, so All right. And then what about social worker for agencies, couple social workers? What about DCS? Anybody from DCS here? Great. Thank y'all. What about teacher, faculty with the school? Okay. Students. Okay. And then other. Okay. What's your other? Tell me what your other is. Do what?
We work at juvenile court and mastery.
Real core. Okay, great.
Non-custodial parents, mainly, mom and dads, mainly dads who are not paying their child support. But we help them knock down barriers if they haven't been there to pay their child support.
Okay.
So they
Okay.
mediators, they're certified Rule 31 mediators.
Okay. Cool. Is that everybody's in that kind of role, juvenile court, or what am I? Where are my others? Wonderful. Thank you. Okay. Okay. Excellent. Great. Well, we've got a good mix of folks in here today. So let me kind of go over what we will be, what our agenda looks like for today. So I'm going to give a really brief overview of what Youth Villages does kind of as a whole and what our footprint looks like in the U.S. And then Allison is going to take some time explaining some of the components of our Intercept program. We have had 3 different rigorous research evaluations that I'm going to go over to kind of help you to understand where we have come from as far as getting Intercept placed on an evidence-based practice list. And then I'm going to go over who we typically serve, the type of kids we typically serve, the type of families that we typically serve, and then what our outcome data looks like, and also a little bit of an overview of our clinical model. And then Allison is going to talk to us, kind of talk you through a success story that she's recently had with one of our families to be able to give you kind of a real life picture of what it was like for a family being in our Intercept program. So to give you this broad overview, Youth Villages is a nonprofit organization. We were founded in Memphis, which is where our headquarters is located, but it's much bigger now than it was back in the 80s. So we are in 27 different states now. On a daily basis, we serve over 11,000 kids and families with the multiple programs that we have. So that's not just with Intercept, that's with all of our programs. We have foster care, we have residential programs, and then we also have a program where we work with kids aging out of foster care called LifeSet. And so that's our 18 to 22-year-old population. So on an annual basis, we serve about 43,000 kids and families and young people. And then we have about 4,500 staff. So we are quite a large organization. Another thing that we have done recently in the past several years also is we have started some strategic partnerships, meaning that we are partnering with other agencies or state departments to implement our programs. And so we have done that not only with our LifeSet programs, but we've also done that with Intercept recently. So that's really taking off with Intercept. So this is what our national footprint looks like. So all of our states that are in red have what is called our internal Youth Villages programs. So that's going to be Intercept or LifeSet, foster care. The states that are in gray are just having our partners program. So these are just agencies that receive our services through our partnership. So you can see on the right is also, let me see if I can move this Zoom screen up a little bit so that you can see a little bit better. So again, this was our current census at the end of February was 11,776 on a daily basis there. You can see on the right with the pie graph, Intercept is our largest program because it has really taken off with what I'll talk about in just a minute, our evidence-based practice being on the Families First Clearinghouse. So we have been able to enter into a lot more states because of those studies that we've done. So our next largest is what's called our LifeSet, like I mentioned, our 18 to 22-year-olds that we're working with. So what I want to talk about specifically, though, today is our Intercept program. I'll be happy if you have questions after this. If you're really curious about some of our other programs, I'll be happy to answer any questions about those. But Allison's going to talk about what makes Intercept different and what makes it special. I don't know if that's going to work or not.
Which one do I hit?
The bottom one. See if it.
The bottom.
Yes. Okay.
So with our Intercept program, there are 5 different elements that we focus on. The first is the family well-being being the whole focus of our services. So we come together as a family, working with the parents and the kids together to identify family strengths and help everyone build new skills. So we come at it with the acknowledgement that kids do well if they can, parents do well if they can, but something is getting in the way of them meeting expectations or goals. And so that's how we want to focus on those skills. So the second thing, the family engagement and collaboration, knowing that families are the foundation of everything we do, it's so important for us to have our staff build that trust and engagement with the families from the very beginning. It obviously, in-home services is a little bit different than doing outpatient services. And so it can be, there can be a lot of emotions tied to families feeling comfortable with us coming into the home. And so with our different models and clinical oversight that we have, we really problem solve with the counselors if they're having any issues gaining that engagement with the family on how to best go about that. And so we'll talk more in future slides about bringing in those systems to help tackle the engagement and collaboration. Safety and stability. So we have, and within our model, we have very specific safety plans that we know, if we're looking at the Maslow's hierarchy of needs, safety is at the bottom. And so in knowing that, we really work alongside with our families and come up with very specific safety plans for those kids in the families. And so we'll talk about that in some future slides as well. We look at communication and problem solving. So kind of looking at the family with their individual needs and the individual things that they have that might be causing family conflict, might be causing a kid getting suspended from school. Just kind of looking at the communication and problem solving from a holistic family or system perspective and how we can really target those missing skills to build and work on for them to be able to have family harmony after they discharge from our services. And then the last thing is the strong community relationships. And so we will touch base about that in the coming slides on how we interact, how Intercept interacts with the different systems that comprise the family. So in the whole family care, we really focus on individualized treatment. So having our evidence-based practices that we have and that we rely on, and you guys will see in the coming slides about the research studies, we really look at how can we work together with this family so that they're not coming back into care, they're not coming back into services. And what does that family need individually for themselves, for the community, to best help support them, and promoting long-term success for the entire family. The engagement and collaboration. So we really have to have the engagement and collaboration before we have anything else, before we have them agreeing to the safety plans, before we really can have the trust of the family that, hey, we're not the experts of your situation. Like, you guys are the experts, but we come alongside them and look at, okay, well, let's identify some things that are getting in the way of meeting expectations or that are getting in the way of just overall family harmony and keeping the kids out of a higher level of care. So the safety and stability, I was just going to share a little tidbit of just a little mini story about how the safety and stability really, it became a barrier in one of our homes. So we had a family, and the client had extreme suicidal ideation, and the mom struggled with understanding that, with knowing how to safety plan around that, and really, because there were multiple families living in one home, struggled with allowing our staff to come in and do a safety sweep. So part of what Intercept provides is myself as a licensed program expert. And so I come to know these cases pretty individually. And I knew that one of the staff was struggling going into safety sweep. So I went on a visit with her, and the mom, they were on the porch, like they didn't want us to come inside. And so the mom had some crafts that she was doing. She was making some different things that some other people might find odd, I guess, like Ouija boards, pendulum, different things like that. But she was in there making them, or she was outside on the porch making those. So I just happened to ask her about those. We got in a conversation, and she said that she sells them at a local market. So I was like, oh, that's awesome. Like, can we see it? And so right with just getting that engagement and alignment and that connection with the mom, she's like, yeah, you can come inside. I'm like, well, while we're here, like, can we do some safety sweeps to make sure that that your daughter is kept safe, and that you kind of know how to do this after we leave. And so just with that little bit, we were able to come in and do the safety sweep, and then also meet the other families that lived in that home. And so it was just really important to kind of dig deeper with mom, but also going back to that individualized treatment that we provide, we were able to look at it from a different perspective and get their buy-in to do the safety sweep. So with the communication and problem solving, we really want to build those communication and problem solving skills to make sure that the family is operating at their functioning, like their equilibrium, I guess, so to speak. Most of the times that we come into the home, it's because of a crisis occurring, or a big thing that's happened that has brought us into the home that's kind of disrupted that family flow, disrupted that communication and process. And so we come alongside, and with our evidence-based interventions, we work with that family to build those skills, to have them have healthier and happier relationships with each other. And then the strong community relationships. So this is where we as a program interact with caregivers, community, including school staff, social services, other service providers. I know we've done some referrals, like for the COE, to have psychological assessments. We work alongside with juvenile courts and work with probation officers, just different people who are supports for that kid and that family, to see how we can get these multiple parties talking and communicating for that youth and family's overall best interest. And we will talk a little bit individually about what these components are that really sets Intercept apart from other services. So the first one is family-centered and individualized. So we do very thorough assessments within our assessment process. When we very first get a new admission, we like to break down the behaviors, and we use a couple of different ways to do that, but basically seeing and identifying what the specific goals, what the specific triggers, antecedents, everything that is happening to make sure that our plans are individualized for that youth and that family. So we might have to have a safety plan, a supervision plan of a youth after school, kind of breaking down what that school after school looks like. And so it's like, meeting Aunt Joe at the bus stop, or, so we're really able to navigate through those specific needs of that family to be able to have plans in place where everyone can communicate for the youth's best interest. We also navigate concerns in the neighborhood. So some of our neighborhoods that we go into, we have to have staff safety plans for, because they might be not the safest after dark, or there might be some gun violence issues or something like that. And so we are able to safety plan for our staff to feel safe so that they can go into the home and help the families feel safe. Because I always let my staff and my counselors know that if you guys don't feel safe when you're doing the counseling and meeting with your families, then it's going to negate everything that you guys have talked about. So just making sure. Oh, yes.
Just a quick question, maybe you'll answer it later, but in the other session where we did the landscape analysis of prevention in Tennessee, something that came up in a lot of the different posters was we're having a hard time engaging families because they were with DCS first and they don't trust. So I'd love to get your perspective.
Yes.
Why and how that's working, because you're describing all these things. I'm imagining not really wanting to go through a detailed assessment with you. So I don't, maybe everyone in the room knows that, but I'd be curious because I feel like that's one of the struggles here and in other states. So.
Yeah, I would say that's been a barrier from day one, at least from my day one, which is a long time ago. And part of that is because there is this view that sometimes families will have of outside agencies coming in, that they're coming in to either, number one, tell me what I'm doing wrong, tell me what to do, or take my kids away. Right. And so it's very difficult for them to differentiate us from what their perceived negative experiences have been. I'm not saying that other agencies come in and do that, but that is a lot of times their perception. Right. And so one of the things that we do, because we do get referrals from DCS, we do get referrals from the courts. Right. And so one of the things that we have to go in and do is say, DCS doesn't want to be in your business, right? They don't necessarily like wake up and say, I can't wait to get into their business and take their kids away, right? That's not their goal. Their goal is to make sure everybody's taken care of and everybody's safe, right? So one of the things that we do is go in and say is, we know that your goal is to be able to live without interference from all these other people that you feel like are interfering with your family. So our goal is that too. Our goal is to be able to get you to a point where you don't need us, where you don't need DCS, or you don't need other court involvements, because we want them to live successfully on their own and not be dependent on us, right? And that's really a big part of what our model looks like, because we do a lot of parent skill building, because we do go into the home, and there may be some kid behaviors that bring us into the home, but a lot of times there's a lot of caregiver skill issues, right? Or caregiver mental health issues, or caregiver substance use issues, right? So we want to address those types of things to make sure that they're stable, that they can operate without us. And so that's something we really push our staff to clarify from like admission session, is that like our goal, like, so we plan for discharge at the admission session, right? Like we want you to get to the point where you're successful, where you have no reason to need us anymore. So that's kind of our mentality from day one. I always tell our staff too that your job is to work yourself out of a job, because we don't want them dependent on us. And a lot of times, because a lot of us came into this profession because we're naturally helpers, right? Like we went into the helping profession because we want to help people. And so sometimes helpers can take ownership of that with the people we're working with. So I always tell our staff, like, you got to build the skills that so that the families and the kids can operate successfully without you, unless you plan to move in with them. And I know y'all don't want to do that, right? So that's really the idea that we kind of put forth. Does that answer your question, to try to make sure that we kind of re-educate and re-clarify what people's roles are, even with like outside agencies like DCS or the courts or whatever, that they're not there because they think you're bad. They're there because they want you to be successful.
Yeah, I think the whole thing about saying it up front and then it counteracts, whether people say it directly or not, a lot of families are feeling like, I have to do this or else.
Yeah.
Yeah. Right. Exactly.
So
That if then, yeah. And you know, it's really hard because a lot of times these families have so many services involved. And that's the good part about Intercept, is that we are so intensive that we try to work with all the services to help the caregivers make sense of, okay, this service is for this thing, this service is for this, right? So we try to bring everybody together to make sure we can work towards that common goal. But that's a great question.
So, Intercept is one of the most flexible, evidence-based in-home program models. So we help children from birth to age 18. We have kids who are involved in child welfare, like we were talking about, like with DCS, children's mental health, or juvenile justice systems. And it's really effective whenever we're using the program for family prevention or preservation, but also including prevention of entry and re-entry into care. And so kind of like what Bonnie was saying, you know, we tell our staff that we want to work ourselves out of a job. And like, you don't like DCS? Well, I understand, because it would be hard for me as a parent to have someone, you know, kind of over my shoulders, making sure I'm doing something. And so we come alongside them, we build that communication and that connection, so that they can meet their goals, so that all these services can get out and they can operate confidently and successfully afterwards. And so some of our research studies that Bonnie will talk about in a minute, it gives the actual numbers of the successful outcomes of our services. Intense and accountable. So our level of intensity, we go above and beyond to support our families. So the cycle that the kids and the families are with us, it's from 6 to 9 months. And it is at least the bare minimum 3 sessions a week. It could be up to 5 sessions a week in the home. And this includes 24/7 in-person crisis support if needed, if there's an emergency. So we have on-call, we have supervisors on call, we have all levels of leadership that are on call to help to respond at any time if there's a crisis. We also have our mobile crisis as well in the different counties. Yeah.
How long were the sessions per week, the flu sessions? How long were those sessions?
Each session is an hour, 20 minutes long. Yeah. So yes. And so we also help attend school meetings. We help attend, you know, court hearings, basically whatever setting that youth or that family's in that needs the most support, we're there. And we are the Intercept specialists are the single point of contact for the family. And if the counselor who's assigned is not available because it's after hours of the weekend, that family knows, okay, this is the EST, the emergency services hotline. This is the number that I call. This is who's, you know, going to be on call this weekend. All of our specialists let the families know, and we plan for that from day one. So they have that confidence in knowing that, hey, I know it's hard right now. There's a lot going on. There's different crises going on, but having that, I guess, like that net to catch me is going to give me that confidence to know, hey, we can get through this. Like, the seats doesn't need to go to residential, or they don't need to go, like, we have this. We have the most support. Yeah.
Well, wait, your data may show that Are you gonna show how many of the kids that enter your program, are on an active IEP? And how many are on medication support as an additional treatment?
Oh.
Yeah, we don't have those numbers as far as how many are on an active IEP. That's not something we necessarily track because not all of our kids need that service, but it is pretty regular that we do have kids that have some type of school issue, whether a 504 behavior plan or an IEP. So we don't have the data on that specifically. But it is something that we do train our staff around as far as like what their role looks like in attending those school meetings. One of the big things that we try to do as well is a lot of times our caregivers have like really low understanding of IEPs and 504 behavior plans and what their rights are and those sorts of things. And so that's another reason why we attend those school meetings is to support the caregivers. We prepare them about like, these are the questions you need to ask. These are the things you need to consider. A lot of times we may go over the IEP with them. So we created resources to train our staff for them to understand what that looks like. Does that sort of answer your question? Yeah.
What about medication support?
Medication support. What do you mean by that?
But how many of the kids that are in this program also are on Adderall,
Oh,
Ritalin?
Almost all.
yeah, a lot.
Other medications?
Yeah, we don't we don't track that particular data, but the majority. It's very rare. Would you say it's rare that you run across a kid who's not medicated?
Yeah, it's rare.
And so again, with the systemic piece of our model, they're getting that medication from somewhere, whether it's a medication manager, whether it's a PCP, something like that. So a lot of times our staff, again, will go to those appointments with the family so that they know the questions to ask. We do, since we're in the home as well, is we lay eyes on those medications. We strongly encourage the parents to lock those medications up. That's a big safety piece. We also make sure they're locking up all other medications because we know that's a big issue right now is, stealing mom and dad and grandparents' medication. So that's a big safety piece. But I would say the majority of our kids are on medication.
Yeah.
So the thing about the population that we serve, with it being as intense as it is we get the kids at the end of the spectrum on the intensity of behaviors. Meaning they've tried all other less intensive services, right? So insurance, DCS, Medicaid, whoever is not going to pay for our services, and because it's 3 times a week and it's more expensive than outpatient, right? So they've already tried all those lesser intensive types of things. So we get the kids that are like at the brink of being removed from the home, either due to caregiver issues or due to the own kids' mental health or behavioral issues. So that's why I would say most of them are on medication.
But Tencare pays for your services, right?
Tencare does pay for our services, yes. But again, they pay for it like only if we kind of need these, like you have to have a diagnosis, you have to, have tried outpatient or individual counseling.
And you're the last resort.
Do it, yes. And I don't know for sure because I wasn't there when they turned the phrase, but I think of Intercept as like we're intercepting the kids from going into placement, right? Like I'm not sure if that's where they came up with it, but that's what I would think. Yeah.
And I know, so you all also provide CCFT. Is this the model that's used for all of the CCFT programming within the villages, or is this separate from?
Yeah.
This is yes.
This-
Intercept
this
is
is
CCFT.
Villages CCFT.
Yeah.
Yes.
Yeah.
Just making
Yeah.
sure.
What other providers, have?
It's not-
Yeah, not that. Yes.
But-
it's the CCS.
Yes. Good question.
Yes.
Sorry.
No, please ask question.
What is the difference in Intercept and like RIP?
And what?
Like a regional intervention program? It's something we commonly use that sounds very similar.
For younger kids.
Yeah.
And that's like,
It's more parent led.
yeah, it's like a therapeutic preschool.
Oh, sorry.
Yeah, you're good.
It's more parent led and it's still the parent, there's the Intercept, which comes with how they work with the parents for sure, but it's they rip also have, they come back mutual with the parents, then have to come back, help other parents out. So it's more time limited, I think.
And it's also the exclusionary criteria on age is only for younger kids, like preschool.
And they don't go out to the home, they're very much at the organization.
Oh, okay.
Yeah.
More of a class type.
Yeah.
Yeah.
Yes.
Okay.
So.
Thank you, guys.
Yeah.
Oh, I think she had.
So in terms of doing your, going over the medications and all of that, Are you all allowed to do like, that you said sometimes if they don't lock it up, people may get each other's medicine? So are y'all allowed to do a medication count?
Yeah, we have, so we don't touch the meds. We direct the caregivers through that process because really it's all about building those skills as well. So we want them to continue that since we're not DCS and we're not, the ones mandating them to do that, but we want to build those skills to have them do that after we exit.
And I usually you all say that sometimes you all, if necessary, you'll go to the IEP.
Yes, yes.
Yeah.
Yeah.
That's kind of like a requirement for our staff. Any kind of meeting they have about the kids, placement, mental health, juvenile justice, anything, I'm like, that's your session. Go to the session.
Yeah, because a lot of our parents can't read.
Right.
Right.
Yeah.
And we have a lot of issues too if they're not English speaking.
Mhm.
So yes, we want them to go, and yes, they can't read. We've had caregivers that also have other type of disabilities as far as if they are are non-seeing, non-hearing, that sort of thing. So we go to try to make sure they have support in that sense. But also some of our caregivers have cognitive disabilities as well. So
And IEP meeting is one of those meetings that's kind of difficult for her.
Yeah.
for sure. Yes.
Yeah.
Yes.
Support there.
Mhm.
Yeah.
Yeah, and I was just talking to someone earlier at lunch about because we're in the community and we're working with the different systems, we're able to partner with some other organizations like Tennessee Voices, who comes in and helps advocate. And so we know a lot about the area organizations and what they provide, and we can bring those people into the support network for that family. So yeah.
Because a lot of families don't know about Tennessee Voices.
Right.
And I can't tell you, because I said we work in like 27 different states. Like I'll go work with another state and I'm like, you have something that can help families, support them through the IEP process. And they're like, no. And I'm like, why don't you have what Tennessee has?
Yeah.
So, I mean, it's such a benefit for Tennessee to have that.
Yeah. Because I'm saying whenever Tennessee Voices walks into those IEP meetings,
Yes.
they know that they're going to be held accountable, and the school knows that they know the laws and everything. And so,
You start 0 to whatever, 17. What are you doing with the young children?
I'll go over that. I'll go over that. Yeah.
that's a good question. Yeah.
Yeah.
We'll go over that. So, Guide Tree is it's our clinical portal manual that we have with youth villages specifically. And this is what we use as Intercept. It's a scientifically based approach. So Bonnie will give you a little bit more details about Guide Tree, but it helps us conceptualize treatment for that youth and family specifically. So with the guidance of the master's level licensed program expert, which is what I am, we have weekly clinical consultations to really look into every kid that is on that specialist caseload and try and identify what is going to be the best, what's going to get the most bang for their buck, so to speak, in the treatment process, and what that family is going through specifically, that we can work together as a team using Guide Tree to use these scientific evidence-based approaches for interventions. And then the long-lasting impact. So Bonnie will give you the results of the study also, but we have been doing Intercept for decades. And we have learned different things throughout that process. But what we have learned is how to generalize and barrier predict. We say those words all the time in consultation, but generalize and barrier predict for not only specifically that youth and the family, but like how that family could maybe teach this model or these interventions to their family members, who might not necessarily have Intercept, but how we can teach the skills that we've learned, but then also keep that kid from coming back services. So Bonnie has the next slide.
All right. So Allison went over a couple of these things already, but I want to make sure I talk about our like key model elements about what makes Intercept so intense. So like I mentioned, or like she mentioned, it is a service that we do admit kids that are anywhere from 0 to 18. And so I'll go ahead and answer your question about that. So what that means is Intercept is what we call a preservation model, but also a reunification model. So a lot of times we will get kids referred to us that are coming out of foster care or that are coming out of residential or whatever. And sometimes if they're coming out of foster care, they're the infants, right? And so the focus of our services is on the caregiver skill building, right? So if a caregiver lost custody of their child because of substance use issues or intimate partner violence or any number of those concerns, then when we start serving the family, we're going to be addressing whatever led to those situations where they lost custody of that child. So that's why like we have to have an identified client, and the way like our contracts are written, it does have to be the child. And so that's why we say infants to 18, if that makes sense. And so we have a mix of that. So sometimes we will get kids that are referred to us because of their own behavior, like I mentioned, externalized or internalized behavior. So we may get kids that are highly suicidal. We may get kids that are getting arrested or getting in trouble at school or those types of things, those externalized behaviors. So we do have a mix of what that looks like. Like Allison said, the model that we have is an ecological family systems based model. So when we even, I'll get into this in a minute, but just to talk more about this, when we even write our treatment plans, we are focusing on who else do we need to bring into services? Who else do we need to talk to? What teacher, what school staff, what neighbor, what family member do we need to talk to? So it's not just working with a kid in a silo, right? Because the focus needs to be the entire system that the kid is in. So let me ask you all, with the kids and families that y'all have worked with and that you have served over the years, have you ever had a situation where a kid went into like a residential placement or a group home or a juvenile detention center long term, had issues before that, family didn't have any services during the time they were in that placement, and the kid ended up doing better, right? In the residential placement, maybe they made some progress, right? And then they got right back into the home and they still had behaviors. They kind of went back to the same thing. I have been seeing some head nods. That's happened, right? So that happens because you're putting them right back in the nature, in the environment that they were in, where it may be toxic, right? Or it may be a situation where the parents don't have the skills to manage what's going on with that kid, right? They don't have the resources that they need. And so the ecological model of Intercept really focuses on making sure that everybody in that kid's sphere, when they are coming back into home, is prepared to continue on that success. And that's a beautiful thing that we are able to even do in the state of Tennessee, is that we have what's called transition cases, those reunification cases where a kid is coming out of foster care, residential treatment, inpatient psychiatric treatment. We're able to open up a case maybe 30 to 60 days before that kid gets back into the home. And we can start working with the parents on safety planning, on communication skills, on de-escalation planning, that sort of thing, to get them ready to be able to help the child not kind of regress back to where they were prior to being placed out of the home. So logistically, what our teams look like is we have what's called family intervention specialists. Those are the staff that go out and see the families. They are on a team of about 4 to 5 specialists. They have a clinical supervisor that's in charge of them. Each specialist will have a small caseload of 4 to 6 families. And so they are required, like Allison said, to see each one of those families at least 3 times a week. So that's going to be about 15 to 18 sessions that they're going to have every week with that family. And so, like we've mentioned before, that session may be in the home, that session may be at school, that session may be at the mental health center, wherever the need is, we can have that session. The flexibility that Allison talked about as well is that we don't have to have every single member of the family in every session. So if we really need to work on mom's transportation issue, like she can't get to her mental health appointment because she has no transportation, we really need to figure that out, really need to address that. Then we can have what we call a caregiver only session, and that can count as one of our sessions. We need to have a family session where we're working all together on triggers and de-escalation planning. We can do that. If we need to really focus on what's going on with the kid, we can meet with the kid in the home as long as there's an adult there, right? But we can do some individual work with them. If we, again, need to bring in another family member, that's like a respite option, or that like maybe grandmother lives in the home and she's part of that family model. We can have like a one-on-one session with grandmother or bring her into a family session. So the flexibility allows us to be able to make sure we're meeting with the right people, make sure we're meeting with those people that have impact on the kid's life. So Allison mentioned the on-call support. The program for reunification, let me make sure, no, the program for prevention. So that's going to be when the kid's already in the home, and we're working on prevention or stabilization. That's typically going to be 4 to 6 months that we can get payment satisfied for that amount of time. If it's reunification, where we're kind of getting in there a little bit early, bringing the kid out of care, usually we can stay for about 6 to 9 months, but that's kind of an average. So anybody have questions? Yeah, I thought maybe.
The reunification one, is there a certain case that has to be open? I know sometimes I've heard like the DCS case has to stay open.
Yes, usually has to be open for that. Mm-hmm. Yep. What other questions?
Do you have any idea of the breakdown of like percentage of the visits that are held with like the family together versus the kid individually or the caregiver individually? Is that anything?
I don't have that right offhand. I will say that it's just a mix, because we really want our staff to critically think about what each family needs. And so with one family, we may see all of them all together nearly all the time. In some families, it's so explosive between the kid and the caregiver, it's hard to even get them in the same room together. So I don't know that I have a number to say like what that looks like. But we tell our families that Intercept is not like everybody gets the same exact thing. It's not like a manualized 12-step program. Everybody gets what they need, you know? And so I don't know what that particularly looks like. I'm sure our research rock stars could pull that number for us, but I don't have it.
So are the workers working like mostly evenings, like weekend, like how? Like,
oh yeah,
school demand, like
yeah, that's a good question.
Their job is pretty offset.
Yeah, so a lot of times those family sessions do have to be in the evenings. A lot of times we will come right after school so that our staff aren't out at 8 o'clock at night every night. We do probably at least once a week. I would say at least one out of those 3 sessions, we're having a caregiver only session. And so a lot of times that can be done during the day. So sometimes our parents work, sometimes they don't. If it's such a struggle to schedule, we can even meet parents in the community. You know, like if they are working and they have a lunch break and they would allow us to come meet them on their lunch break, we've done that before. I will say, me personally, I don't want us to have all of our sessions outside of the home, because we need to be in the home looking at the safety. Like that's our number one concern. So we try not to, and like in Allison's position being a program expert, she talks to staff and has consultation with them weekly. And so she's asking them, where did you do your session? Who was in the sessions? That sort of thing. And so we're trying to keep an eye on that so we don't have all the sessions out of the home. I will say a lot of our staff will meet with kids in the school. They can maybe pull them out of, some type of class. But I'm also very careful about advocating for that, because we don't want them to miss learning, right? And so if there are major school issues, we may do that, and we may even bring in like a school counselor or something into that session. So that is something we can do. Some schools are totally against that though. So it's really just dependent on the school as well. Yeah, good question. Yes.
Year and a half, or 2 years, at least for, families that have received Intercept, with Family First FFPSA thing, it is kids 12 or older. Is that, representative of, children with for families that are served in Tennessee more broadly? Because of course, care, as you mentioned, pays, or other sources pay. Is it mostly older kids? This is my question. If it's so, is that unique to Tennessee or is that better?
So you're saying, say that again about
About 80% of the families that have received the FFPSA has paid for Intercept. They're 12 or under. The child was 12. I'm sorry, 12 or older. So is it mostly older kids?
Yeah, it's a good question. I actually have a slide that tells us the average age.
Okay.
And the average age is 12.6. Yeah, so you're like right on the mark, but it does vary. It does vary. So I think yeah, I don't know. I don't know if it's just for Intercept, but the 12.6 is across all of our states. The 12.6 age median is across all of our states. I think we are probably within the past 5 to 10 years just started like admitting a lot of younger kids. Whereas prior to we were like getting a lot of older kids. Yeah.
So as a former DCS employee, when Intercept came on the map, it was very much shown as a pilot. That word pilot, I know that's not everywhere.
Yeah.
And it was like pilot for 12 and older. So my question then is, I know how it was implemented in Tennessee. If you're seeing this between all of the states, when you're first implementing in the states, are you running them as pilots for like 12 and older?
Yeah. So the Intercept, so DCS, the Intercept pilot, that was a pilot just for DCS.
Okay.
And so because Intercept was funded by TennCare, which was not a pilot.
Okay.
And so that's probably where the word pilot came from, is because the specific funding source or funding stream through DCS was maybe a pilot.
Yeah.
But yeah, it had the term pilot attached to it for many years, like after it was like I know it's hard to let that die. Yeah, I know. Yeah. No, it's definitely not a pilot. Yeah, we've had Intercept going since the 90s. And so it's definitely not a pilot anymore. And I would say in all of our states, we do offer it as, 0 to 18. Some of our states are more focused on prevention. Some of them are focused more on reunification. And so that does like then determine maybe what age range we're going to get. Right? Does that make sense? Yeah. Yeah. Good question. So, yeah. Okay. Yeah.
Sorry. So I had a question about the reunification. So if you all open a case while a DCS case is pending and it's that reunification focus, and DCS wants to close the case because the family is reunified, but your all's program is ongoing. Could you switch from DCS paid to TennCare paid?
You are talking about something that's way outside my lane. Eric? Okay. So yeah, I'm like being Eric only on Zoom calls.
My name's Eric Aaron. I'm the program representative manager for the state of Tennessee. So to answer your question, absolutely. DCS, the pilot came from, as Bonnie said, pilot just refers to the funding. It does not refer to anything other than just funding. So whether it's TennCare, grant funded, or pilot, which is now TN DCS non-continuum, all the same programs, just talking about different funding stream. Now, as far as what you're talking about, if there's an open FSW case or the child's in foster care and bring them home and say that judge says, you know what, family's doing well, we're not even going to do a 90-day trial home period, we can immediately, as long as we have a diagnosis, we can immediately submit that to TennCare, and TennCare knows that our service being in the home is going to reduce the risk of that child coming into custody. So they will approve for us, provide services up to 120 days after they step down.
And the child has to have a diagnosis.
Yeah, ma'am. So anytime we bill through TennCare, there has to be a billable diagnosis and there has to be a lesson.
NAS, is that available?
What is it?
NAS, neonatal abstinence syndrome?
That's not gonna be, so with TennCare, they're gonna typically look at kids between the ages of 4 and 17 because they're gonna look more along the lines of the kids' behaviors than the parents' behavior. But when a child's coming home from foster care or residential treatment, they understand the risk of that child going back into it, especially after the honeymoon phase, so they're more willing to pay for the service.
As long as it's just one kid. For the whole home.
I'll let Bonnie answer that question.
Are you talking about having multiple kids have the service? Okay, so we can do that. It's a little tricky because that means that family's got to have, if they're 2 kids, that means that family's got to have 6 sessions a week, right? And so, because we're not going to go out there and only give them 3 sessions when we're getting paid twice, right? So, so that feels, icky to me. And so it just depends on what the situation is. You can also try to put in a referral, like once one kid is discharged, if there is a need for the other kid to have services, then we can get it through TennCare. Then we'll put in a referral and try to get back in the home as long as the family is willing to continue on with that. So, does that make sense? Does that answer your question? Yeah. So we have done that where we've had multiple kids because the risk is so high. And as long as the caregiver is willing to have us out there 6 times a week or 6 hours a week, then we'll do it. But that's a lot for a caregiver. I mean, I'm not sure I would do that, but but some caregivers are like, yeah, I'll take whatever help I can get. Please help me not lose my kids.
We've had it to where there's been funding in our continuum where we've had like a sibling group of 3. So that's 9 sessions a week. And we let the caregivers know that. So they're very well informed in advance as part of the step down plan. And that's what it's going to look like. But each child, and most of the time they're younger kids whenever they're that many and everything. But each individual child might be affected differently from that separation from their parent. And so, 9 sessions.
So the other thing I would say too is that because our clinical model itself is a systemic model that reaches to everybody in the home. And so if there are siblings in the home that have behavioral issues, or we need to make safety plans for those siblings or supervision plans for those siblings, we can do that. We would say that to have like a second kid as also a client, that their behaviors are so extreme that they need the extra help. You know what I mean? So we can make safety plans for the whole family, because it is a family model to be able to do that. So I don't want to negate that idea either, that we can serve everybody in the home, but if it feels like something very specific for that other sibling needs to be addressed, then we can do that. Yeah. Okay. Couple of other things. One of the big things that I feel very passionate about, because it's something that I oversee at Youth Villages, is our program model fidelity review. So we have all these different things that we're doing at Youth Villages, and we're saying we're doing well, and we're an evidence-based practice, but we got to make sure we're doing it right. And so each one of our offices goes through an annual program model fidelity review, where we look at over 200 different measures to see how are we doing. Are we doing Intercept the way that it was meant to be done? Are we being successful? We're interviewing and surveying staff and families. We're looking at all different things about quality of documentation, timeliness of documentation, to make sure that we're doing it right. And so that's something that we do as a way to kind of a self-check. Also, it's also offered us for those families. I think a lot of you know about the Families First, payment and drawing down federal dollars to implement different programs. We've got 5 different states right now that are doing that. We've got probably 4 to 6 more states that are in the process of drawing down Families First. And we've been able to use our internal program model as part of their core quality indicators that the Families First programs require to be able to say, are you actually implementing Intercept the way that you should? So we've been able to use that to show like how well we're doing and where we need to also grow as well. So we have been able to have 3 rigorous evaluations of our program that have resulted in us being on the Families First Clearinghouse as a well-supported program. So when we started this process, we used Chapin Hall out of the University of Chicago, and they are our kind of third-party, non-biased evaluators at the Center for State Child Welfare Data. So Dr. Fred Wolchin is the one who ran all of these studies. So I just am going to give a very brief, because some people may not really care about research. So I'm going to give a very brief overview of what these studies were able to show us. So we had 2 studies that showed us that we are successful at preventing out-of-home placement, and we had a 3rd study that showed us that we are successful at maintaining permanency. So our first study was done, and it showed that it's a comparison group between kids that had DCS referrals receiving Intercept services versus those that did not receive Intercept services. And so this was done over a longer period of time, and 53% of the kids that received Intercept services were able to be maintained and not be placed outside of their home versus those that did not receive Intercept services. So the big part of this is this right here. The big part of this study that really stood out is that the sustainability of the impact that the Intercept program made, because they looked at not only did we prevent out-of-home placement at that point in time, but also 12 months after. Was the kid still in the home, or was the kid in placement, whether that be foster care, residential, group home, whatever that looks like. So a similar study was done over a smaller period of time. It was more of a unique sample of kids. And again, in this study, Intercept prevented 37% of the kids from going out of home placement. So that is a positive result, that if you received Intercept, then you were 37% more likely to not be placed out of the home. The permanency piece, where we're looking at was the family able to maintain permanency after they came back into the home? Again, 24% of the families that participated in Intercept were able to live with their families continuously versus those that did not receive that. So those studies then allowed us to be rated the highest rating that Families First gives, which is well supported, which has opened up our doors to be able to implement in many different states. Even in the past couple of years, we've opened up, I think, in 3 new states because they have started pulling down Families First dollars. So this is going to allow us to grow and serve more families, thankfully, across the U.S. And so we're very excited about these opportunities that we're given to be a prevention service and be able to reach more families than we would without this. So any questions about the studies? Anybody have any questions about that? Yeah. Sometimes it's a little dry. Research is a little dry. So talking about how Intercept is growing. So just looking at the growth that we've had in the past probably 17, 18 years now, total Intercept kids that we've been able to serve since 2007 is 71,000 kids and families that we've been able to serve. So again, you can see kind of the breakdown by states about what our numbers look like. Obviously, Tennessee is our biggest state because this is where we started. So over in the past 17 years, we've served 40,000 kids in the state of Tennessee. And then we have some other big states, Massachusetts, North Carolina, Mississippi are other big states. So that's what that has looked like. And then somebody asked this question, like the average age of the kid, 12.6 years. So that is the average age of what we're serving. You can see here the typical ethnicity of the kids that we serve. So most of our kids are Caucasian, and then we've got a fairly big percentage that are African American as well. It's about split as far as gender goes. Yeah. Yeah. Okay. So our gender is about split as far as like if we get girls and boys. So it's about right down the middle. And these are the highest presenting issues that we have. So behavioral issues is kind of our number one reason for referral. And so health concerns, legal issues, the self-directed violence, suicidality is a big piece of why we're getting services or why we're getting referrals. So anybody have questions about this or the type of kids we serve? Yeah.
I'm just curious with abuse and neglect,
Yes.
is that purely exposure to abuse and neglect, or is that like post-traumatic stress symptoms, or would that be captured under behavioral? Just curious, right? Like we know exposure is not necessarily
Abuse,
pathological.
Yeah. Like exposure to like intimate partner violence or like other trauma in the home. Yeah.
Any kind of.
Yeah. I think it would probably be lumped in with abuse and neglect. Now, like with our clinical mindset, when we write treatment plans, we do piece that out some to focus on like exposure to like the trauma, toxic stress exposure, or if they actually have been a victim.
And also along with that, given the prevalence of behavioral issues in the population and mental health concerns, do you have a sense of what percentage of your population is also getting like evidence-based individual therapy in addition to that? Yeah, a lot of times they will have received that before we come on the scene. As far as, and we always, like if a child has been exposed to some trauma, we do try to make sure that they are getting some sort of EVP trauma treatment. Unfortunately, because we do serve a lot of kids in rural areas, that access is not always there.
Yeah.
They may not have access a lot of times to like TFCBT or EMDR or things like that. So that's a big concern for us in rural areas.
Yeah. And I would piggyback off that. We have a lot of kids, at least in the Knoxville area, where we have a lot of kids who are on waiting lists every year. And so part of our aftercare, like Bonnie said, starts from day one. So one of my first recommendations is always we need to get this kid on a wait list for individual therapy. Like they need this, and this type of therapy. And so we're working throughout the entire time they're with us to have that aftercare. But it has been recently, I've noticed, really hard to get into.
So is it considered aftercare? So from y'all's perspective, like it's an aftercare after Intercept or it's concurrent?
They can, we would love for them to have it concurrently because we do want to support them in starting that treatment because sometimes it can be really difficult. And a lot of times we do try to connect them and make that referral if needed. Yeah.
Question. When you showed all the other states, are those all states where you have youth villages, facilities?
Yes.
Or so train or other agencies can adopt this program?
Yeah, all of these are direct youth villages services.
I didn't know you had that many facilities in other states.
Facilities, you mean like residential?
No, like youth villages.
All of these. Oh yeah, all of these states, and this may not even be. Yeah, this is updated. Yeah, yes, we're in. Gosh, I can't remember the number now. I think it's 17 states where we are in. Where we have what we call direct youth villages services. And then we have, I think maybe 8 to 10 other states where we partner with other agencies and train them how to do our programs.
Oh, wow, I didn't know that.
Yeah.
I just noticed in the numbers on the next slide, do you do things focus on like being culturally responsive?
Yes, absolutely. That is a huge thing that we're even like really trying to enhance and bolster up our resources on that. We've actually even partnered with an outside agency to come in and make sure that all of our materials and how we train staff and our resources and interventions are what they need to be. And so it's a huge push for us. And so because we are seeing a lot of other ethnicities that we maybe don't have a lot of resources for. Just as an example, there is a conference going on right now in Orlando for work with Native American and Indigenous peoples. And so we just don't have a lot of resources on that. I've got one of my staff that's attending that conference right now so that she can bring us back resources so that we can create that. So that is a huge, huge piece, and it's a huge push from Families First as well. And so that's something we do. I will say also, I don't think we're going to get into enough time to be able to talk a lot about our Guide Tree online platform. But our Guide Tree online platform is a way for our staff to access clinical tools and resources and interventions. Every single one of those has a cultural competency or a cultural considerations section to be able to say, like, this is how this would work with, you know, different cultures, and these are the things you need to be asking and thinking about as you implement this. Yes.
So we have, some specialists that speak Spanish.
Yes. 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 In some of our areas, it's actually required. We require that we have that. If we know that we have a certain population, that we have a big Latino population of referrals, that's definitely something that is really prevalent in our Massachusetts offices, also in our Oregon offices. And so we have like a push to make sure that we have at least probably one person on every team that speaks Spanish. So, and we do translate most of our resources into Spanish as well as we give out interventions and handouts and that sort of thing for families. So we are running up into our time. So I'm going to do a couple other slides. We're not going to be able to finish, but I'll be happy to send any of this information to you all. If you all are curious to have this PowerPoint, I'll be happy to do that.
Sign-in sheet.
Oh yeah, I can do it with the sign-in sheet. But just our outcomes, just to let you know, overall, we do have a really robust research department that does a lot of follow-up with our families at 6 and 12 months after discharge to see, how are you doing? Is your kid still in your home? Are you having any other legal issues, educational issues, behavioral issues? And so we have a 92% of families being satisfied with services at 12 months after, well, maybe this is it. 12 months after discharge, almost 90% of our kids are living in the home with their families, or if they graduated, they're now 18 or 19, they're living independently. 98% of them are either in school or they've graduated. And then 92% of our kids at 1 year after discharge have had no trouble with the juvenile justice system. So that's a pretty big success rate, something we're really proud of. That, again, that goes back to the sustainability piece of our program, is that we give the families, the caregivers, and the kids the skills to be able to operate successfully on their own. So I don't think I'm gonna be able to finish the rest of it. So I think we've got 2 minutes, right?
Yeah.
So what questions?
I'm just gonna make a quick announcement. Anyone who needed CEUs, we are having technical difficulties with the Survey Monkey. So you will get an email to fill out information on this session at a later time to get your CEU. So don't fret if you don't scan the code and do it right after this. That's all I got.
Okay. Any lingering questions that you all have? Yes.
And that's gonna be based on the sign-in sheet then, so I need to sign the sheet.
This is our whole state of Tennessee and the different offices. If any of you guys want to make a referral for Intercept, I passed them out initially, but if you guys need extra or whatever, you can return.
Yes.
It may be hard to know for the whole state, but do y'all generally have a waiting list for families?
That's you.
I'm sorry,
No.
No. Did you say no?
So, for the most, you're always doing something free services with them, what my team does. So I would say typically referral probably get services on average within 7 to 10 business days of getting on the phone, which is pretty standard. Now, there are some areas where there may be more rule or things like that, but during the time that we're waiting to get an FIS in there, we're helping that family maybe increase their modalities with their individual therapists or medication management. we're doing some basic safety with them, helping them, we may drop off a lockbox or something like that. So we're continually checking on that family at least once a week while we're waiting to that FIS play. But I would say in most of like Knoxville, most of the metropolitan, like Knoxville, Johnson City, Nashville, 7 days mostly. I mean, on average, would be where I put it at.
Great. Other questions? That was a great question.
What about Memphis?
Memphis.
Give me a referral today, I'll have it Friday.
Yeah.
Oh, if you give me a referral today, I'll probably have it tomorrow.
But most of the people, the team specialists you send out the bachelor's level folks, right?
Most are bachelor's level. We do have some master's level staff. But it's kind of a mix, master's and bachelor's level, but that's why we have a licensed person that oversees everything that they do, oversees treatment planning and that sort of thing.
You're like a licensed therapist or?
Yeah, she needs,
LCSW.
Okay. got it.
yeah, so they'll either have somebody that's LPSW, LPC, LMFT, some type of clinical license. And that person, again, they have to sign off on treatment plans. They meet with staff every single week to go over cases and case conceptualization.
I came in late, I apologize, but I'm sure they said it, if they didn't. We cover all 95 counties. If it's in the state of Tennessee, Intercept.
Great question. Yeah.
What's your staff retention rate like? I feel like a lot of agencies, we start with one person serving our family
Yeah.
and then they're.
I have no data on that. Do you have any?
I don't have data, but I can give you some anecdotal thing. I've been here, Sunday will be a decade. I've been with Youth Villages at this point. Retention has increased because we've done things such as having dashes, which are each FIS has a computer. We have emergency support, so they're no longer on call 24 hours a day, but we have an emergency support team that are trained in those situations where now the FIS is just on call with the family from 6 to 6, but then we have trained family intervention specialists who can help reduce those issues over the phone and people that are on call that can go out and handle those things. So I would say we are going to have some turnover, but I would say maybe, we see one to two every other month or so, but it has decreased over the last.
I think that is,
7
yeah.
to 10 years.
We have tuition reimbursement, we have license reimbursement, we have a lot of interns will come work with us and do their internship and then go on take a full-time position. So there's a lot of
Incentive to stay.
yeah.
Incentive to stay. Yeah, like you get your whole licensure paid for, all your licensure supervision paid for. And then after that, get your renewal fees paid for every year, get your CEUs paid for every year, that sort of thing. So. Yeah, great question. Thanks. Y'all have been so great. In order to get through everything, we'll email you the PowerPoint. And if you have any questions, you want to